Okay, Chair, we're live and running.
Good evening. It's now 7:01, and I'd like to start the meeting of the Health, Wellbeing, Overview and Scrutiny Committee. I'd like to remind everyone present that this meeting is being recorded and filmed. Item 1, apologies for absence. I've got the superintendent.
Councillor Polly
Yes,
and Councillor Snell is in substitution.
That's it. Nothing. Item 2, minutes. I move that the minutes Health, Wellbeing, Overview and Scrutiny Committee held on the 2nd of September 2001 to be approved as a correct record. Does any member have any comments on these?
Page 7, paragraph 3, we were talking about the social prescribing. It says that Health Watch are being managing it. It's not. It's Thurrock CVS hold the contract for managing it. It's just in that other hat of mine, I oversee it, not Health Watch.
Thank you. Any others? Item 4, declaration of interests. Does anyone wish to declare a declaration of interest? No, thank you. Item 5, items raised by Health Watch. Kim Jones, do you have any items?
Not tonight, thank you.
Thank you. Item 6, community impact beds on community inpatient beds in Mid and South Essex. Unsafe Grave, James Wilson, Andy Vowles, Claire Hackley, Hanky, and Dr. Sarah Zavy and Tina Stitch this evening. Could I please ask James to present this item, please?
Thank you, Chair. I'll run us briefly through the slides, and then it'd be great for any questions. I'm conscious we've got kind of duality of colleagues here, so please let me know if you can't hear me. My role, I work for a combination of EPUT Provide and NELFT, who are the free community providers who work across Mid and South Essex, but also part of my time look at community commissioning across the Mid and South Essex patch. And the purpose of the item that we've brought to you today, so the second slide on your pack, is to share the work that we're starting to look at around the future location and volume of community health inpatient beds. We're very much at the start of this process, so we want to discuss the initial plans that we want to commence around engagement on a number of the key issues that we'll come to in a second. Kind of the backdrop to why we want to look at the community inpatient beds, and agree with the committee how we move through this engagement phase and develop the options that we expect we'll have to go to consult on in the near future, and the criteria that we'll be using to determine what those options now are evaluated. The next slide just gives a bit of context, so slide is headed up context 1 of 3, about why we're embarking on this piece of work now. So I'm sure members of the committee will be aware we had to make a number of urgent changes during COVID to support patients and meet their needs and demands during the height of the pandemic. And we're at a point where some of those changes, we need to decide whether they should remain or whether we should revert back to what we had, or if there's another option that meets the needs of the patients in a better way. It is obviously well documented, though, that the demands on the health system is still very much with us. Across Mid and South Essex, we've got over 7,000 people still waiting a significant period, over a year, for some of their elective care, and a high number of people on waiting list still. And that backdrop in terms of waiting times has really been emphasised by COVID. And so we need to, as we're considering the future volume and configuration of beds, be cognizant of those acute demands and pressures on the system. There's also work that started looking at the stroke rehabilitation side of the pathway, considering how the changing demands for that service and the potential configuration of that service in the context of the national outcomes that have been published, to ensure that we can meet the ongoing outcomes for that patient group, And also it's in the context of the work we've been doing around our ageing work programme, looking at what's the optimum model to support patients in their own home where that makes sense, but also in a bedded setting, what's the right clinical model to support patients in their care needs there. The next slide, context 2 of 3, gives members of the committee an overview of what the configuration of beds looked like pre-COVID. And then the slide, the next one in 3 on your pack, which was in the paper that was submitted, gives you an overview of the current configuration of beds as we stand today, taking into account some of those changes that I mentioned that happened during COVID. What I'll do now, Chair, if it's okay, is pass over to Andy Bowles to just give you an overview of some of those key issues that we want to explore during the engagement phase.
Thanks, James. So yeah, as you can see on the slide, the 4 main areas that we'll be keen to get into engagement, and Claire will talk in a moment about the process for engagement that we've got planned. But the first of those, as James has touched on, is around the acute frailty provision, and I'm sure the committee is aware, but one of the urgent changes that was made, it was a number during kind of COVID, was moving some inpatient care for frail older people away from the main Basildon Hospital site and into Brentwood community. A couple of drivers for that. One was that enabled clinical care to be expanded in the hospital, which is a key pressure, as you all know, during COVID, but also a better separation of streams at that point between people who had COVID and people who did not. And the decision before us that James alluded to earlier, and that we want to begin to engage on, is for we to decide as a system. So is that a good model going forward, having those 2 wards in Brentwood? Should they go back into the hospital, or indeed is there another solution? So that's the first issue for engagement. The second is, as a team, and Sarah's our clinical lead, has been doing some great work on intermediate care, and we need to come to a view across the system about the right number and the right locations for intermediate care beds in the future. And obviously there's a number of things that are relevant there, not least connections with wider services, so community services, adult social care, etc., and want to begin those discussions. The third of those is around stroke rehabilitation, and I'm sure members of the committee are aware that there's really strong evidence about the importance of specialist rehabilitation after people have had a stroke, and has a huge impact on their outcomes, and that's really clear. It's also pretty clear from initial work that we may not have the right number of beds in Mid and South Essex. We're likely to need more specialist rehabilitation beds for stroke. So that again raises the question of how many beds in the future, where should they best be located? So that's the third issue. So those are the 3, if you like, service issues that we want to be engaging on: acute frailty, intermediate care, and stroke. And then the 4th is a process issue. At the moment, we have a lot of possible scenarios and options. Obviously, we need to begin to engage to narrow those down, and we'd like to use the engagement process to see what people think about a set of criteria that we're developing that we'll use to assess different options to begin to narrow it down. And then if we get to formal consultation, that will inform any kind of preferred option that comes out of that. So those are the 4 kind of key issues for engagement. I think Claire's just going to give a little bit of an outline now. Sit behind me.
Thanks, Andy, and sorry for being in the back row. Hopefully you can hear me okay. And so our engagement approach will obviously be seeking the views of patients, staff, carers, stakeholders and partners on what's good about the current services and what works well about the current services, but also on some of the potential changes that Andy's outlined. We're looking to bringing an independent partner in to help us deliver that engagement approach for part of the phase, particularly around that targeted engagement with those most likely to be impacted by any of the potential changes that could be made to these services. And we'll base that around the quality impact assessment that will be done as part of the process that we're going through. We'll do a range of activities across engagement, and we will certainly link in with our kind of community and voluntary sector partners, and certainly our colleagues in Health Watch will be a part of that work that we want to do in terms of putting on workshops, focus groups, and making sure that we have a really kind of accessible set of ways in which to engage in the work that we're doing. We want to work with some key groups around the kind of demographic that uses these services, such as Age UK, Essex, the Stroke Association, carer support associations, and obviously, as I mentioned, our BCSE network. We've got excuse me, we've got a system-wide citizens panel that we've set up across Mid and South Essex that's a representative population of our demographics, 1,500 people that we regularly survey about issues that we have going on across the system. So we'll look to survey them around the principles that we've outlined in terms of the changes, and certainly around that work about the criteria that Andy mentioned. And we'll also link with our existing engagement networks across the system to make sure we can gather insight from pieces of work that have already taken place, to make sure we're not duplicating activity. And then on to the next slide, gives you an outline of the timetable that we're proposing. So today, this session was with the Scrutiny Committee, and so it almost kind of kick-starts that engagement process. So later this month, we hope to launch our kind of pre-consultation engagement phase, and also start the assurance process that we have to go through as an NHS body to through the NHS England to make sure that we're following the correct procedures. We'll also begin engagement with the East of England Clinical Senate, which is an independent group of clinicians who will assess the kind of clinical models and options that we're starting to develop to make sure that they are clinically sound. Then earlier in 2022, which I can't quite believe we're nearly there, we will start to share those conclusions from the engagement phase and look at what we've learned through those discussions and conversations to start to pull together a pre-consultation business case, which will set out the main issues and options for this programme, which we then may want to look to go to consultation on if it's required. And then we will obviously develop a plan and timetable for consultation, and obviously we'll look to want to discuss through that committee about that approach. If we do go to consultation, we would then look for that to take place around spring 2022, with then a decision on the preferred options on any outcome of the consultation in the summer next year. And then finally, just to kind of reiterate why we're here this evening and why we want to kind of engage with your committee. Firstly, we obviously want you to note that we're undertaking this piece of work, we're starting out, and our plans to kind of engage on future options that we may want to develop. We'd like you to agree to receive regular updates from us on this programme. And then just a note there that potentially we may need or may want to request that there are joint committees formed across Mid and South Essex with colleagues in Essex and Southend, as this is a kind of MC-wide piece of work. Thank you, Chair.
Thank you, Chair. Thank you.
Yeah. Thank you. Thank you, Paul. I know we've had meetings before regarding this and ongoing conversations regarding the consultation that's going on and the changes that are suggested. First of all, I'll say that the stroke side of this, I'm fully supportive. Now, I know there may be a payoff for some residents where their loved ones may be go to a different area outside of Thurrock. But if that is for the best possible care, there's a payoff for that. We've had experience years ago where we had family members going into a heart attacks, going on to rehabilitation somewhere else. And that is the success rate that shows, again, if that's put into the same practice with the care rehabilitation, I don't see a major objection to that. I think it's a really good idea. Get more specialists in one place, that side of it. And also there are concerns about the use of community beds. It's on that note as well, before I'll come back to those questions. I'm sure there's other questions coming in that are going to address what I'm going to say. I would say that I'm very wary of the joint host. I've been a part of that the other day on the meeting. It's obvious that one size don't fit all. So if we are just one voice as Thurrock in a joint group of hosts, we could easily get voted. And so we could be relinquishing power to other hosts and other areas. So that is where my objection would come in there. I'm very wary of that side of it. First question will be going to, I think it's Joe Corbin on mic.
Thank you, Chair. Can you hear me okay?
Yes, that's fine.
Good, thank you. Thank you for the presentation of the paper. I wanted to ask, if I may, about the stroke rehab beds. I'm sorry, I'm not that familiar with the stroke pathway in Mid and South Essex. And I wanted to ask firstly, do we have an early supported discharge service within Mid and South Essex, and has the evidence base around stroke early supported discharge been taken account of in the calculation around the number of stroke rehabilitation beds? And I asked this as a former lead for the stroke pathway in North East Essex, and when we introduced early supported discharge there, we got really good results in terms of patient outcomes, but we also got a reduction in community beds. And the point you made, Chair, about patients being closer to home, obviously early supported discharge is delivered in the home with the same intensity as it would be in a community hospital setting. So it's good. There's a lot of positives for both families and patients in that model. Thanks, Chair.
If I maybe start, Chair, and then I may pass over to Dr. Zadie. So I think that it's worth noting that the kind of early thinking around volumes needs to be kind of developed during and fed from views by this engagement process, and ultimately is worked up in the pre-consultation business case. So I think we're at this point thinking that there will be a need for more, but we need to kind of refine that work. There absolutely is the early support discharge service across Mid and South Essex that kind of complements where people need that bed-based rehabilitation where it's not appropriate to be supported in their own home. But Sarah, I don't know if there's something.
Yeah, welcome your question. It was the same question I asked when we first started this process, and obviously I'm not the stroke lead, but I am aware that the factoring in of the ESD activity and also the home first mantra in general, which also applies to intermediate care. So really everything that we're doing, our modelling is around getting us to a place where we are aligning ourselves to best practice in terms of optimising outcomes. But I think the early indications from that stroke modelling was even accounting for ESD and even increases in activity in ESD, there is an inpatient intensive rehabilitation slight shortfall that we've always had, and where the expertise has been sort of spread quite thinly. And what we want to do is make sure that we have that, really intensive expertise consolidated and meeting the demands of that more intensive bedded rehab group. But absolutely, ESD is going to factor in and has been factored into the modelling.
Thank you. Councillor Holloway.
Yes, thanks for your presentation. Can you please talk the committee through specifically the impact it will have on Thurrock's care and Thurrock residents, please?
I think that the point in the process we're at the moment, that there isn't a definitive set of options that we're coming to the committee. We're coming to the committee saying we want to start exploring through engagement what those potential options are, and then the criteria from which we'll assess them. And at that point, we'll be able to have more definitive view on what's the impact for Thurrock residents, both for the intermediate care and for the stroke in particular. At the moment, what happened during COVID, where we talked about a number of changes to intermediate care beds. So kind of pre-COVID, you had a number of intermediate care beds in Mayfield ward, and there's now still in Mayfield ward. So in terms of volume change from pre-COVID to now, that hasn't significantly changed. But it's something that we need to explore overall in all of those options. Is that right for the future? Should there be a different configuration? And that's one of the things that we need to look into, along with the stroke and with those acute priority beds. But I guess, and the reason we're coming very early in the process is to ensure that we've got support from the hosps, and we can get the right feedback and to determine what ultimately those options and then the impacts are, and we fully understand those from all stakeholders' views.
Okay. Another query. What kind of elements will you look at when you're drawing everything together? Because it is very general. What is it that you look at when deciding and making this kind of decision?
Yeah, so one of the elements that we want to engage on is the kind of criteria. So the types of things that we'll be looking at, we'll bring those back to the committee. We think, well, what does the evidence show the impact on outcomes is likely to be? There will be a piece around patient experience, so the kind of trade-off often between access, close access, physical access, and outcomes as part of that. There'll inevitably be a financial component in the sense that we don't have the ability to create new facilities when we work across kind of Mid and South Essex. So there'll be some of those as well. Well, that is, as I said earlier on, that getting those criteria right is really important as we move from engagement on the issues into refining down into the options. And part of the reason I want to share the criteria that we will use for decision making as part of the initial engagement.
Okay, thank you. I mean, I would say it is very, very general, so it's quite hard to comment on a very, very general report. What I would say is, of course, I would agree that we always want the best care for patients, and we have obviously previously supported specialist areas of care. But what I'm really, really mindful of is that the best care can sometimes always be configured outside of Thurrock. And for us, for me specifically, it's very, very, very key that we actually keep the beds in Thurrock. Now, I'm sure every hospital say this. However, we have got there is a real concern at the moment where we are kind of losing services outside of Thurrock and it's interesting to see what these reasons are. And how, if we could in Thurrock mitigate some of these where they come. But I am absolutely vociferously against kind of moving that ward, which did temporarily move during COVID. So I would be firmly against kind of any kind of reconfiguration where we lost that capacity, which is desperately needed here in Thurrock.
Councillor Fish.
Thank you. I'm interested to know more about the kind of patients that are considered suitable for these kind of beds. It's the process that when they arrive on the in hospital, they're assessed to see whether they're suitable for this kind of bed, and if so, is that based on the length of time that they're going to be spending there? Because one of the things I'm trying to find out is how you're going to work out what capacity you need of beds to meet the needs of all the patients adequately.
It's a good question. So, there's sort of three types of service need that we're providing here, as Andy has described. So the two things that we've always done, which is intermediate care. So what that means is that somebody's had and this is how it's been operating at Mayfield and the other units for a long time, where an older person very often, or somebody who's had a serious illness and they've been left with a level of disability after a hospital episode of care, usually, where it's recognised that that person needs a period of intensive rehabilitation. So we have physiotherapists and various teams that will work with that person to try and improve their function and their level of function for a level of time. And nationally, according to sort of national standards, it's usually somewhere between 3 to 4 weeks that somebody will spend in that step down. So that's from hospital and then stepping down. And similarly for the stroke, it would be specifically people that have had a major stroke where their disability is quite severe and they're unable to have the supported discharge at home, which is always the first priority, because people often do better when they're at home, but where we can recognise that they would be needing a period of intense rehabilitation for a while in order to optimise their outcomes before they go home. So that's been the sort of standard practice and is still, recommended good practice, recognising that we know that for older people, getting them home as quickly as possible is also good for them. So that's the sort of cohort that we would be serving. I think the question that we will be asking is, during COVID, one of the new things that we started doing, which was the acute frailty beds at the Brentwood site, was in that situation you'll often have an older person or somebody who's particularly frail who's gone to hospital. So they very often have gone to Basildon Hospital first. They've been identified to have a mild illness, so they're not severely unwell. They just need very sort of low-level medical input. It might be a couple of days antibiotics or something like that. They're not seriously unwell, and for those patients, currently they've been moved to Brentwood for a short period of time, usually about an average about a week, for that medical treatment before they go home. So essentially getting the same as what they would get on an acute ward, with the same doctors and nurses and same staffing model. So that's sort of groups of patients, and I think the decision that we're making is, do we have the right model of care? Are we really optimising the best outcomes? How do we perform benchmarked to sort of national standards? And where should that bed configuration be?
Okay, thank you.
Thank you. It's something dawned on me that it would have been useful if we had produced a Q&A from the hospital we had prior, because these questions were covered in there. What I'd like to see, I'm aware of the bigger picture of how I deal with doing both, where we're growing. Ian, would you like to put an input on this, on how future prospects of QBS, how we have vision growing?
I think there's two phases to this, as Andy and I discussed previously. So I recognise there's an immediate need to work out what we need to do with the current provision. I think in terms of our longer term or medium term transformation, we have an aspiration to build an intermediate care facility to a slightly different model of residential care. And linked very much to a virtual ward, clinical reach, and our wellbeing teams. So we are currently working at those plans, and they will be in the Thurrock Alliance strategy that we'll bring back to this committee. But I appreciate that the opening of that is probably 2 or 3 years off. So this work proceeds to that further. Ultimately, I think it's really important that we decide potentially we're mindful strategically.
Thank you. Yes, Kim, I was actually coming.
That's all right.
Come to you next.
Thank you.
Yeah. So.
Thank you for this, and I look forward to working with Claire to gather the views of people in the Thurrock, because I think there's going to be some feedback, so be warned. I take on board what you're saying, Chair, and the real need for specific care further on for people with stroke. I do think there's going to be some concerns about them being so far away for people that don't have access to relatives. We fought really hard to keep the stroke unit at Basildon for that reason, because of concerns about travelling and getting so far away from it. I used the services myself. I had a stroke, and I know how dependent I was on my family, on my rehab. And if we're going to have older people that are so far away and their relatives don't have access to them, that's a concern for me as well as on behalf of people. It's just, you know, I understand it, but both of those are a bit of a distance. Not as far as Brentwood to there, but I mean, we've had people that sort of concerned that they can't even get to Brentwood. So that is going to be a bit of a shocker to them, I think. So we just need to be wary and be ready for how that's going to be managed and their discharge home.
Thank you. Yeah, frankly, really appreciate that. I mean, it's great to have that experience that you can bring to a person's term for us. And as I said, I was worried that all of a sudden we was going to end up having some building in the back room of roofing where we can put our stroke patients out and get to see. What I guess my concern was, which I asked before in the other meeting, was regarding the specialist help. If we are setting up these places, we would be losing that expertise from someone like Basil. That was my concern. Are we pushing things further away out of our reach, that they may not be getting the quality of care that we want here, because we're not dependent on these specialist places?
I think the point, Chair, we're at in the process is, with Kim and others' help, that we want to design those criteria to evaluate what's ultimately the best configuration and the optimum solution, because there's always going to be a payoff, sort of way up between the close geography and kind of that specialist centre, and we need to work through what's important through this engagement exercise. People think in terms of the criteria, the weighting of those criteria, and that will then, and what are the potential options and scoping those out. There might be options that we're thinking of that and other people consider that we haven't thought of, and then ultimately that goes into the mix that then we can, through this process, engage the wider public and then ultimately consult if that's where we land to determine that. So I think that hopefully the committee can see that, because we're not coming here with a fait accompli about the process and the design, we really are at the start of that, and that co-production hopefully will then ultimately deliver the best outcome that's right for the whole population.
Yeah, just a thought on the
if a specialist unit does move outside of Thurrock. We know how important it is that family support at these times can make a great difference. So is there a possibility, and I know this might be a bit off the wall, but is there a possibility of looking at, even if it's only once or twice a week, putting a transport link on from Basildon Hospital to the specialist centre, so people that want to get there but can't get there could actually go to Basildon Hospital where they would have gone anyway and get transported there and back?
I think all of those things that absolutely need to be taken into consideration as part of the weigh up of the options. And if there's a disproportionate travel time from a certain geography, then absolutely we need to look at what's the alternatives to support people to get there. Because as you say, having that family input into their rehabilitation is really important, in particular for the stroke patients.
Yes, so it can be difficult, especially some of the elderly people that might want to get there and give that support. May not feel happy going on public transport, wherever it is. So that's something that I think would be well worth looking into.
Okay, yeah, thank you for that. I say we're sort of into the first minutes of this game, so I think what part of this podcast is to agree to have regular updates. We can, I don't know how we've got that into our work program was at the end, but the second statement needs to be put up to date with. Obviously, we do this in June, so that we sort of run through. So the rest of the recommendations were. Was tonight, was it? Yeah, to agree, to receive those updates, so further. Just quickly, just that's all right. With the joint bus.
Yeah, I don't find them particularly helpful, to be honest with you, having sat on one previously. I don't think that, as I said when we spoke, everyone wants what they want for their area. They want to keep the provision in their area. So I don't know how a joint cost would necessarily, we'd all meet and then we'd all want it in our area and then we'd go away. So I don't, unless we are presented with something practically that's not going to result in that, which is what has happened when I sat on them previously, I don't really see how they would be, I don't see how that would be helpful.
Experience on the same house.
We sat on it together. So yeah, unless that happens, I would not, I probably would remove that for everybody's sake. I don't think anyone wants to sit at the meetings where we're just not being able to move forward. We will never, as council, never agree on that one. So.
Okay, thank you. We'll move on. Thank you for your report.
Thank you very much.
Yes, you may leave. Thank you for your time.
Unless I'm really not
Nice to see you.
Thank you.
Okay, so item 7, adult housing and health fees and charges pricing in 2022-2023. This is this one. Yeah. None of us are getting any younger, and I know we're trying to save paper. Please bring out the stuff you do. I have to use the microphone now as well. So, okay. So we have Catherine Wilson. Would you like to present the item?
Thank you, Chair. Good evening, everyone. I'm Catherine Wilson. I'm the Strategic Lead for Commissioning for Adult Social Care, and I'm presenting this report this evening regarding the fees and charges pricing strategy for 2022-23 for adult social care. And I agree, Chair, I wish it could be a bit bigger too. I think it's a finance thing, making things small. As members will be aware, the process around fees and charges is a corporately set process, along with the framework for the report that I'm presenting this evening. Consideration is given each year within each directorate for what potential there might be to evaluate current charging levels. As is evident from our report at this stage, we are not making any proposals to increase charges for 22-23 other than the proposal that has already been agreed and is currently being implemented, which is a 3-year incremental increase to our domiciliary care charges. The domiciliary care charging proposal underwent a detailed consultation, and the outcome and recommendations were presented to HOSC and Cabinet earlier this year. The appendix to this report details our current charges for adult social care. As noted, these charges are either statutory, regulatory or discretionary. So, for example, our charge for a blue badge is £10, and that charge is set nationally, so we're not able to increase that. The majority of adult social care's income is realised through residential care charges along with domiciliary care and some of the other charges, of course, that you can see on the document that you have. As noted in the report, all people who access services are offered a financial assessment, and a very small proportion of people who receive their services would pay full cost. Most people would pay a small amount, a proportion towards their service. And I have described in the report the process for a financial assessment. So at this stage, we're not proposing to increase charges for adult social care for the next financial year. An increase in charges has not been built into the savings targets at this time. However, the purpose of bringing this report is to ensure a consistent approach across all directorates, highlighting the already agreed domiciliary care charging increase, and to ensure that as a committee you are reassured that if the position changes and an increase in charging within adult social care requires consideration, then we would undertake a detailed piece of strategic work that would cover such areas as statutory duties under the Care Act 2014, the levels of demand we have and the impact of the pandemic as examples of things we would look at. And any proposals to increase charging would then be subject to a detailed consultation. The second recommendation is to ensure that HOSC are aware that delegated authority would be sought to vary fees and charges in year once an initial increase had been agreed. But again, just to reassure, any proposal to increase adult social care fees and charges would be brought back to HOSC and Cabinet in year for any agreement to move that forward. Thank you, Chair. That concludes my presentation.
Brilliant, thank you. So you need to start getting these reports now like this. Although I did hear Councillor Holloway scream with delight when I opened her letterbox, because I know she's been asking for a president for this, and she'd like to see our DVD charges. I think it's great to see this, and also we've agreed these changes up front, so we know what's coming. To see this in front of us is reassuring that nothing's been changed. Apart from that, I don't really have many more questions on it. Councillor?
Yes, thank you, Chair. Yeah, I was delighted to see the breakdown of fees and charges, but I would have loved to also have seen the wider directorate breakdown of finance. And so just to double check, the first thing is just a 100% double check that the spreadsheet that we've been provided is just for info. It's just what the current fees and charges, and there's nothing. And the second thing, it would be helpful to just provide a bit of financial context in which the financial charges sit. And lastly, with regards to the recommendation on delegated authority to vary within the financial year, it is, thank you, Kathleen, for confirming that any changes would be brought back to Cabinet. I think I'd like that written in to the recommendation, so it's there and it's written into the recommendation also it goes to Cabinet, because sometimes they don't always mirror, because otherwise I'd be very concerned that they could be changed in year with no scrutiny from us or Cabinet or full Council if we ever have a meeting. Yeah, so that's I'd write that in. Thank you, Chair.
Yep, 100% agree with you. That's all right. To have that added into that as one of our recommendations, any changes you could for us straight away. Ian.
Just to reassure you, that's absolutely the case. Furthermore, charges for action taking consultation service users, and that would be attached, and that would come back to us. So we've got a
Thank you. Did you want to, who wants to provide, Catherine, on in a bit more about the wider financial context in which they sit, which is
so the financial context in which we sit at the moment, as you're aware, because we discussed it at today's meeting, is challenging the council. Still has about £3 million deficit for 22-23, which we are closed at the moment, and a further circa 10 million. 24 is, as you would rightly expect, a huge amount of work going on in the background to try and come up with further proposals to close. In terms of my directorate, we have a comprehensive program transformation on this agenda in terms of private services. That's got a savings target of just under £5 million for 2 years. But I'm quite proud of it, that we've attempted to do the lion's share of that through genuine service transformation to improve outcomes. And actually improving outcomes doesn't always cost more money if you the services in a person-centred.
Thank you.
No. So move to recommendations. 1.1, health wellbeing overview scrutiny and degree consultation. Should be completed. This one. Yeah. And 1.2, health wellbeing overview scrutiny noted by the authority, which is sort of happening. We will note that part once it will come. Yeah, changes on. Thank you. Catherine. Catherine, you're another second. Catherine, you can log off if you want to now.
Thank you very much. Thank you.
Okay, item 8. For health and wellbeing strategy refresh. Can I ask Joe to present this item, please?
Thank you, Chair. And apologies, committee, you've got an awful lot of papers in relation to this item. I would, if we were in a different circumstance, go through a PowerPoint presentation to give you a more detailed, well, sort of more visual, I guess, overview of the health and wellbeing strategy and what we're doing. So apologies that that's not possible at the moment. We are, as the paper says, we are in the middle of a consultation about the refresh of the health and wellbeing strategy. And I'm bringing this item today to get input from the committee on the proposals that we're consulting on. The Health and Wellbeing Board have agreed the vision for the Health and Wellbeing Strategy refresh to be levelling the playing field. So levelling the playing field and addressing inequities across a broad area of the wider determinants of health. And the health and wellbeing strategy has quite a broad base to address those broad determinants of health. I would refer you, probably the best overview is on, I think, page 55 of your papers, which gives an overview of what the 6 domains of the proposed strategy are. The first domain is around healthier for longer, so focusing on supporting individuals to live longer in good health, live healthier lifestyles through self-care, through healthy choices, and with support from services where that's required. The second domain is about focusing on the communities, so how communities can work together, how we can support the community to create a fair, accessible and inclusive borough. So this is around supporting in communities to have their voice heard by promoting opportunities for communities to come together, etc. The third domain is around how we are remodelling and transforming care, and this committee has heard over recent meetings about various aspects of the transformation of health and care services, both children and adults. And under this third domain, we try and pull together a high-level overview of the changes we want to see through health and care transformation that will support individuals living healthier and longer lives. So the first three domains, I think, are the domains particularly for that this committee may wish to focus on, and I'll talk about those three in a little bit more detail in a second. But the other three domains, are 4 through 6, are focused much more on the wider determinants of health, so those aspects of our everyday lives that impact on our health and well-being status. So domain 4 is around opportunity for all. This is quite a broad domain and starts with opportunity from birth, so educational opportunities for both children, young people and adults, employment opportunities, so securing good and meaningful employment, and also some of the focusing on the backing Thurrock agenda and the economic growth agenda within Thurrock as well, and how we create opportunities for all, with a particular focus on those who are most vulnerable and have the most capacity to benefit. Domain 5 focuses on housing and the environment. So this is around the provision of high quality, affordable housing, addressing homelessness, but also how we plan and create the built and green environment to promote health and well-being. So a key element of this is around how we use the regeneration in the borough, the local plan, to drive the creation of environments that reduce the risk of crime, that promote physical activity, and a whole range of ways that the environment can support health and well-being. And then the final domain 6 is around community safety, and this is very much aligned to the priorities of the Community Safety Partnership. For each of these domains, we've had either a small working group or an existing group, such as Stronger Together Thurrock has worked very much on the second domain around community cohesion. We've had a group of stakeholders that have pulled together suggestions within that domain and the proposed priorities that we have for each of them. We've worked with stakeholders from across the system. We've also consulted with assistant directors and other leads within the council and pulled all that insight together into the proposals that are now within the consultation before you. We've got a number of ways that people can input to the consultation. So if you flick back a couple of pages to, I think, page 53, the consultation arrangements are outlined there. So we have firstly a consultation through the online consultation portal of the council, and we have a separate page for each of the domains and for the overall approach to try and elicit from people who wish to give detailed feedback, that level of detailed feedback, and the link is in your paperwork there. We are also have got a variety of face-to-face engagements, whether that's sort of virtual or in person. So our partners in Healthwatch and Thurrock CVS have been absolutely key in helping us get to this point, in helping us shape the consultation, and are really actively engaging with the community on our behalf at the moment. I understand from Christina Jackson that up to 30 engagement opportunities have already been undertaken, and there's a programme where our CVS and Healthwatch colleagues are engaging through the activities that they have with community groups, and are bringing the health and wellbeing strategy into those discussions. And Kim will probably be able to give us a bit more detail on that if the committee wants. We're also attending meetings such as this and other meetings of stakeholder groups and community groups within the borough, and are inviting anyone who's involved within a group that might be keen to speak to us in more detail about all or one particular aspect of the strategy to get in touch with us. We'd be very happy to come and talk to people through that. And then we're asking if individuals would like to participate in any face-to-face workshops. If there's enough demand, we will set that up as well. So that's the consultation process. And the detail of the health and health service elements of the strategy are from page 57 onwards in your pack. The sort of documents from page 57 onwards are ones we have again developed with the help of CVS and Healthwatch. They are a summary of the proposals that are in more detail on the website to enable CVS and others to have conversations with people about what the proposals are and capture their feedback on those. So, for example, in Domain 1, we've identified some of the challenges around inequalities within the borough. We know that smoking and obesity rates are higher in Thurrock and indeed are higher in more deprived communities in Thurrock, and these health behaviours drive a lot of the inequalities that we see. So a lot of our priorities are about addressing smoking and obesity, about improving the identification and management of long-term health conditions, about supporting people of all ages, particularly at times of transition between services, and also understanding the needs that have been exacerbated because of the COVID pandemic. So we're trying to cover a range of health needs within this domain, and the other domains are similar in that they cover a range of priorities. And I'll probably stop there, if that's all right, Chair.
Thank you, Jo. A few things. So, first of all, who wrote the questions? Who wrote the questions, Jo?
Sorry, I didn't catch that.
Who wrote the questions?
Who wrote the questions? So this was very much a team effort from, we've got a steering group that includes council and NHS and CVS and Healthwatch partners. So the topics, the priority topics were identified, as I said, by these task and finish groups of stakeholders, and then we tried to turn those into priorities that we could use in the consultation. So the priorities were very much a group work. The actual questions in the consultation were drafted by council colleagues. The engagement team were quite instrumental here.
Thanks, Jo. Before this went out, did this go in front of any councillors at all?
It's when it was sorry, the consultation documents.
Yeah.
So Councillor Halden, as part of the Health and Wellbeing Chair, has obviously been most cited on this and signed these off.
It didn't go in front of his board, his committee.
So it has gone to the Health and Wellbeing Board, yes, but that was just last week.
And that was after it was public.
Because the September meeting was unfortunately cancelled. So yeah, the timing has gone a bit awry there.
That is concerning. How many replies have we had so far?
We've had a lot, actually. We've had a lot of hits on the website, and we've had, oh, I haven't got the numbers in front of me, but we've had several hundred hits, individual hits on the website. And in terms of responses, we've had, I can't remember, but something in the region of 50 or 60 individual responses. That's on the website. As I said, the CVS are doing a separate engagement as well. And I understand from Christina that there's been at least 30 different places where engagement has been undertaken, and we're going to, like I said, a number of stakeholder groups. So we've got a variety of ways of people feeding in, but actually it's been quite good so far, the response.
I've been 3 people so far.
Oh, yeah.
They're all K's or C's, so it's fine.
Yeah.
We CVS are leading on this, and Health Watchers are of it as well. What we were asked to help with this to go out. We felt it was massive. We sat and done a great big piece of work once we got the document on the way it was worded and the amount of questions and how confusing. This is a bit of a shorter version than the original one, isn't it, Jo? Because we said you can't possibly go out with the amount of questions on there. The first page the first bit on page 55, if you have a look, that's quite simple, just sort of like covering the domains, and then just a couple of questions really about them. We're taking this out, so we can't take this out. What we are doing is going out to groups with this, but then if, just say for example, it was a health support group, say a stroke group or something, we would then probably do a bit more around domain 1 with them, and then ask them if they was interested in any of the others. If it was a community sort of group, we might go out, they might ask if they want to do a bit more on domain 2. But we are doing the words to it, we are talking it, we're not just giving it to them, we're actually going out and doing face to face. We do have a plan of about 30 different places that the Health Watch staff are going to children's centres, to talking shops and everything, just really to ask people if they're aware of it, give them some information, talk to them, cite them to the site if they want to take part in it. But the bit that we're trying to do is at least get some kind of feedback, but we are having to talk around what it is, to explain it, because just giving them this, we're not getting, they don't really understand what they're being asked.
Thank you. You sort of made my next point for me. Is that without the added information, I think some of the questions could be seen as almost leading, and you need to get more. No, these are awkward. I understand your problem. You don't want to give them like a biography to read about each domain. But then to ask them that question, I think it's a tough ask what you're doing. And verbally, you're doing a better job than probably just in this consultation online. I don't know. So, Councillor Holloway, can we?
Yes, that's okay, Chair. Thank you. I will first off say, as I have done all along, I think we all agree it's an absolutely brilliant bit of work and really needs to be done, and it's fantastic. The breadth that it covers and the topics that it covers, and yeah, everything going on behind that. I think specifically on the consultation itself and the wording itself, it absolutely isn't written for a resident. To be honest with you, it's jargony. It makes sense it was written by someone from the council. You know, the question about, do you agree with the aim of this domain? Like, do you agree with this topic area? Even the headings are very jargony. It could have just said, you know, health and your community and jobs, and like there was no, I think it hasn't been written for a resident, and I think that's a real shame. How long does it take to fill out would be my question. And who has it been sent to? Because yeah, I think it's a missed opportunity, because I know that residents would love to feed into this, but if they were advised to click on this, then it's really off-putting, and I don't see as many responses as possible, unfortunately, because it's just bad. I'm sorry, for residents, it's bad.
Thank you, Councillor. From experience over the last couple of days, it's roughly about an hour.
I mean, realistically, who's got an hour to fill out this kind of survey? I think we just really missed an opportunity to really condense it, every topic, into a couple of questions. And I know while they're complicated, it's just a real missed opportunity to engage with residents, I think. And is there any way we can really reduce it and really try and get more residents? But 5 minutes, 10 minutes tops is how you want to be doing this, not an hour. It's just not going to happen.
I actually had somebody who commented today encouraging people to complete it, that said, please set aside 3 hours. And I thought, oh my God, it is a bit too technical for some of the elderly residents to sort of understand and look into what is the domain, what does that mean? Unfortunately.
I agree. I think it's that common sense approach which did raise the question of who wrote them, who agreed them. I agree with Councillor Holland. We've missed an opportunity here. This is out in the public domain. It's probably too late to do it now. Maybe we may have to rethink the strategy that we're taking on this now. Jim, obviously the work that you're used to doing verbally putting this out is probably better than the consultation itself. Sorry, Kim, do you want
Can I just say that, I think that this, I mean, this is the refresh. This has come over from the original, and there have been some changes, but we did have the original strategy, the health and wellbeing strategy, and Health Watch did lead on some work in that, but we had more time then. We were able to do, I think we had nearly a year, and we went out a domain at a time. And I think they weren't up to called domains, and I think they were called priorities, and we went out one at a time. We done a massive piece of work in one, and then we fed that back to the board, and then, but there just hasn't been the opportunity for this, and I think that's what we're finding. It's too much all at once, and that's why we are now going out, doing the verbal bit with the smaller one, and then just picking which domain is most appropriate to the group of people that we're talking to, and doing it that way, and then just saying there are these, because for some, the community safety one is really important, no matter who, whatever their group is. They want to do the health one, but they also want to do that. Some people, it's really important that they do the housing bit. But for us to try and sit in a group and do the whole lot at once, we found that that is a real struggle. People, they're there for a cup of tea and a knit in that group. They don't want to be there an hour later with us saying, what about this one? So by going through the first one, when we have crib sheets, so we're all telling the same story by saying these are them, these are the priorities we're saying, and this is what it is, and like expanding on it. But obviously COVID has stopped a lot of what we would do. The groups are just not, there's not as many groups, so we're never going to hit as many people as we would have in the
I
past,
understand
and that
that.
circumstance.
I do understand that, but we still have an opportunity here to try and think of a little bit different. The thing I'll bring Councillor Cook and Councillor Ian, do you want to come in on something?
Kim's kind of named quite a few things that I wanted to say, but just a few comments on this. The strategy itself is deliberately broad and needs to be applied. The board, we were really keen that we did something that addressed inequality in its entirety, rather than focusing on a few areas. So that immediately sent us with a change. The second thing I wanted to say was just the document is one mechanism of engagement. So what Kim is doing is part of that engagement. I think your constructive criticism is constructive and probably well made. Without wanting to sound like somebody who's trying to make excuses, I'm going to try and make excuses. And Kim kind of said it, we ideally would have done this over a much longer time period. We haven't been able to do that because we've been through the pandemic. Looking at that, the strategy has run, or the last strategy has run out, and there's a strategy to have a strategy. So we were in a position where we knew we had to do something quick and probably not as comprehensive as we really would have wanted. What I'd say finally is that engagement and where we want to move to the engagement process is actually continuous conversation. We need to move to a point of actually consulting on individual structures and services, because that's our world. They live their lives through places, and they live their lives through a whole range of different factors coming together. So I think that the process of engagement itself will change, and we're in discussions with Health Watch and CBS, and Christine and Kim and I are actually having quite frequently on for this meeting. So I accept it's probably not as great as it could have been had we had more time, but this isn't the only part of engagement. Engagement doesn't stop. The strategy is high level. There are a series of objectives that we're refining, but we need a continuous process of engagement at the family level, integrated, which is sufficient.
Yeah, I had a shortened version of the questionnaire sent out today by CBS, obviously. I actually put it in. It's slightly different, well, it's a lot different to this one, but one of the things that was on there, it comes under section 4 of your domain name 4, if you call it that. Whilst totally accept we want people to do the best they can and give them the opportunity to improve and progress, we've got to be careful that we don't make the person that's a dustman that wants to be a dustman, and by all what's can only ever be possibly a dustman. Because we're not all geniuses, we can't all say we've got to make sure they don't feel neglected or allowed or something. So I think there needs to be something in there to say that it's all right. We're giving the opportunity for the people that can achieve it, but we need to make them know that a dustbin is just as important as a doctor. Because without the dustbin, we would need more doctors because of the pandemics that are going about, whatever else. So I just think that somewhere in that bit, there needs to be something that doesn't make people think, oh, I can't do that, so I'm focused.
I think if we've learned anything from this pandemic, is the people who thought they weren't valued were now the most valued people in this country.
I was just thinking in terms of suggestions to take what you've said and the length of it. I wonder whether, Joe, we could just put something at the start to say, these are the domains, and please select one or more, depending on what interests you, so people don't feel they've got to fill the whole thing out if the whole thing is irrelevant to you.
So I think on the website we do have that. The reason there's sort of so many versions of it is that people can just give some kind of overall feedback, or as Kim said, just focus on one area that's of interest to them. So we're not necessarily expecting everyone to work through it page by page. But yeah, I can look at the wording and make sure that's clear. Yeah.
I didn't notice that otherwise I would. Big fun section. That's the stuff.
Yeah, thank you, Chair. I mean, most of what I was going to say has already been said, and it's the same as ever. I think sometimes we don't learn anything from previous consultations where we want information, we want the public to give us the information, but every time we do it, it's like this. It's long, it's cumbersome, it's a chore to figure it out, frankly. Having done a few of these in the past, one particular one springs to mind, the Fairness Commission. We were actually dragging people into, can you fill this form, please? They're looking at it, no, it's too different, too long. And you might have been able to achieve a lot more with listing the domains and then listing maybe 5 or 6 tick boxes underneath each one, so people can just go tick, tick, tick. These are my concerns, hand it in. You need to get people to write things down. A lot of them just won't do it, and that's a problem. Design choices. I looked at this online earlier, and the thing that jumped out at me was, why is the health and wellbeing strategy accompanied by a massive wave of smog that's covering up all these health symbols? And it's a horrible grey, bluey load of smog. I just thought it was a bizarre design choice, and might be a petty sort of thing, but on top of everything else, it doesn't add to it really, does it?
Is it grey? Is it grey on the website?
It is. It is.
Oh, okay.
Actually,
So it's not just like this.
It's a grey, blue. It's just nothing more than
Halloween version.
It looks just like a load of smog coming across Thurrock in a health way. It's strange design choice, I thought.
I really liked it personally.
Now you see it.
Beauties in the eye.
I can't unsee it now.
But yeah, but I do agree with everybody else. It's I can see where you go with it, but it is far too clunky. And as Councillor Holloway said, it's not written in human.
Thank you. I do have one final comment on it. There's nothing in there about alcohol. And obviously alcohol has a major effect on people's health and lifestyle, which we will touch on sometime in the future. I was quite shocked there's nothing in there. Not on smoking and that stuff. Apart from that, I just forget some. I just want to say that I agree with Councillor. This actually is a really good piece of work. It's just that I think mainly the criticism is about online, about how it is put across online. The face-to-face engagement you're doing is brilliant, because that's where people really engage with you and they can understand it, and that is where you'll get your best results from. Apart from that, Councillor,
yeah, just a final thank you, Chair. Just to say, hopefully where everyone's attending the forum meetings, because I think that there are lots of engaged people there, I'm sure that goes without saying. I would also say that I don't agree with Councillor Ralph that it is too late. Like, I think this is such an amazing opportunity to reach so many residents that literally, doing a 5-minute, 10-minute survey on SurveyMonkey, if the comms team can't kind of pull that together in a really, really basic way to get some kind of data, even if it's not filling boxes, it's just options to get, and then you could get hundreds if not thousands of responses, because you would say this takes 5 minutes to fill out, and then people are like, well, okay, I've got 5 minutes, and tell them the time as well. So I think it really is best practice when you're filling out things to say, this is going to take you 50 minutes, or this is going to take you 10 minutes. I don't think it's too late, and I really, really, really would like if we could put just a very short, quick, you know, so it could reach even further, because as all the comments say, like, it just, nobody's going to reply, and I do think everyone should feed in. 50 to 60 responses is good for for our consultation purposes, but it's nowhere near good enough. And I know from engaging with residents that they have so much to say. Every councillor would say they've got so much to say on these topics. So hopefully it's not too late and we could not have too much work on, but if the comms team can't knock that off on Saturday, I'll be so surprised.
What's the deadline?
Joe?
So Joe, what's the deadline on this?
The 6th of December or thereabouts.
Okay, so yeah,
So we've got about another month.
take that away and have a look at that.
Yeah, I'm talking basic now, like, you know, don't use these words.
Can I just say that there has been a delay in this? There was a delay to start with it. The first week was delayed, just getting paperwork together for it to go and signed off. We've had a delay because we've had major problems with our IT to get even stuff printed up to get it out there. So there has been, although we have been getting out there and doing this, there has been a delay. So I think that there is going to be a request that there's an extension on it, because realistically, 8 weeks is a very short time anyway, and we're virtually down to 6 weeks that we can actually physically go out and do it. And we have got our diaries absolutely chock-a-block. We can't do anything else. We're even going to supermarkets if we've got spare hours. We're taking them home and going to our neighbours. We're doing everything we can, but we still, I think, lost a couple of weeks, like proper work at the beginning. So I think there is going to be a request to say, can we maybe that last 2 weeks we can get something together that's just short and knock it out there in social media, and you know, that may be something we need to discuss at the meeting.
I will say, I mean, I didn't really see much of it on social media.
We've had nothing. I don't know about the local authority, where they've been pushing it out from their comms team, but from our side of it, from CBS and from Health Watch, we have been completely down. With our whole service been down for the best part of 2 weeks. We have a virus, so we haven't been able to push anything. We're only just about up running.
Surely that must for an extension. So I don't know if you can get back to me on the chances of an extension on this. Well, your basic sense is we've been up against it over that.
We'll take it away now.
Yeah, brilliant. Thank you. Thank you for that. Now, script. Yeah. Members note that the consultation exercise consider the purpose, the opportunities to engage the public interest provided during the consultation period. That's it. Yeah. Okay, good. As I say, we've made our recommendations, what we'd like to see. Thank you. I'll put it this way, I've actually got really bad migraine at the moment. I've got fuzzies in my eye. Item 9, COVID update. Can I ask Joe to present the item, please?
Yeah, I should say I'm finding it, quite hard to hear what's going on, so apologies for that. You should have a copy, I think, Jenny, of the slides. So obviously normally I would go through a slide pack with the committee, and we've printed out these slides. Can I just remind committee members that some of this data is quite sensitive. It's not for general public release, it's for management and oversight of the pandemic. So if I could just ask you to be mindful of the copies that you have at the end of the meeting, that would be really helpful, thank you. So I'm just going to give you an overview of the latest data that we have on COVID. So on slide 2, you've got the current picture of our positivity rate and how our positivity rate compares with our neighbours. Our positivity rate for the latest 7 days data is 358 per 100,000 individuals. For comparison, back in January, the positivity rate was about 1,500 per 100,000. So although rates are higher now than they were perhaps back in the spring, they're nowhere near as high as they were back in January. Our positivity rate back in the summer was down about 1%, but you can see now it's over 8%. So we have got sort of medium levels of COVID within the community, and have had since July, really. If you look at the next slide, slide 3, the graph on the left shows a 7-day average of positive tests, and you can see since July the rates have been fluctuating between about 50 and 100 cases a day, but they've stayed up there. They're not falling back down to the low levels we had back in April and May. The graph on the right just shows the test rate, and the test rate and the positivity rate have sort of mirrored each other. So we're not seeing kind of peaks just because we're getting more tests done. It is about that positivity rate of about 8% as per the previous graph. So the next slide shows the breakdown of tests by age and gender. We have consistently had higher testing among female residents. You can see that there are low levels of testing across all age groups. We did see that black bar at the bottom, which is our 10 to 19-year-olds. Back at the start of September, that was much greater. There was a lot of testing among school children at the start of term, and that has gradually reduced down since then. So slide 5 shows the age breakdown of those testing positive for COVID at the moment. And for the past couple of months, our highest rates have consistently been in that 10 to 19 age group. And about 2 weeks ago, that positivity rate in that age group was over 1,000 per 100,000. It's now down to about 650. And I think that's partly due to the impact of half term, reducing mixing among that cohort, but we've also taken some measures with schools to try and stop spread between year groups through sibling transmission and that kind of thing. So we've taken a number of actions with schools, and that does seem to have brought the positivity rate down. We'll have to see what happens in the next couple of weeks in the second half of term. That the group around 40 to 50 has, for the past few weeks, also been the second highest group, and we suspect this is something to do with familial transmission. We have got low numbers now in the over 60s. However, over the past month or so, we have had increasing, slowly, but increasing rates in our over 60s, which of course is of a concern, as that group's likely to include a number of our more vulnerable residents. So we just need to keep an eye on this. But the overall trend for the past sort of 10 days has been downwards, mirroring that fall in the case rates in teenagers. The next slide, slide 6, shows COVID bed occupancy in BTUH. You can see that after, again, a very low numbers back in May, June, we've had a consistent, but thankfully much lower than earlier in the year, consistent number of COVID beds occupied, and a few with mechanical and non-invasive ventilation, although most are just oxygen therapy. The next slide shows our vaccination uptake in the various different age groups and risk groups. The uptake of the vaccine in the over 18s has pretty much stalled now. We're getting very, very slow increases. So I think everyone who is keen to get 2 doses of vaccine has had 2 doses of vaccine. We have lower rates of uptake, as you can see, in the younger age groups, and that's still being rolled out, of course, in the 16 to 17-year-olds and particularly the 12 to 15-year-olds. So 12 to 15-year-olds, there is the school-based programme for vaccination, and they can now also book through the National Booking Service. So we think that will be useful in increasing the numbers within that 12 to 15 age group. Of course, there's been a slowdown because of half term there as well, but the numbers are increasing there. The slide with the map shows the distribution of cases, and all of our unique postcodes within the borough have at least one case in the latest 7-day data. We don't have many of the darker blue areas, which is good because that means there are more cases in local areas, but you can see that the highest case rates at the moment, or the highest number of cases, are within the sort of Purfleet and Grays area, and much of the rest of the borough has some but low numbers of cases. We've got just 2, well, I think we've probably got slightly more than 2 now because this data was from slightly earlier in the week, but we've got at the start of term we had sort of 20 odd schools in outbreak. We now only have a handful. The 13 of those that are still recovering from outbreak. We only have 1 care home with a live outbreak, which is really good. You'll remember earlier in the year that was also a much higher number. So community transmission has begun to decrease. And we've got much lower activity in the high in educational and care home settings, which is good. So in conclusion, our positive rates increased steadily from the end of September up to about the 20th of October, but have fallen off since then, and we're now at about 350 per 100,000. We are in the lowest third of local authorities in the country, so although rates are higher than we might want, they are certainly nowhere near as high as some of the other areas in the country. As I said, our case rates are highest in our teenagers, but that rate is again falling. Our geographic distribution of cases is diffuse, but we don't have clusters with high numbers, we don't think, in any of the geographical areas. So our key priorities are continuing to maximise uptake in all adults, and again in our under 18s who are eligible. The key messages that comms are continuing to push remain the same. We're promoting twice weekly LFD testing, particularly for those in schools. The hands, face, space message hasn't changed, just be aware of others around you. Good ventilation is one of the best preventative factors still, although it gets more difficult as we get into winter. And one thing we're really trying to promote is that anyone identified as a close contact of a case should get a PCR test, and this does include household contacts of cases and siblings of cases as well. And that's it.
Thank you, Jo. Thank you for keeping track of all this. I say, like yourself, I try to keep up to date daily with the numbers. And as for Thurrock goes, I do see places like Basildon were going up to sort of 900 cases while we were still sitting at 400. It was just very weird how they sort of spike and go down, and how it changes so quickly. A couple of questions I had. One was regarding the case rate being the 60 to 69-year-olds. Is that transferring to hospital numbers for that age range?
Sorry, was the question about the ages of hospitalisations?
Yeah.
Yeah, I don't have that to hand. I don't know if we have an NHS colleague in the room who might be able to elucidate that.
Yeah, I don't have that level of detail.
Then I guess my second question will probably get the same response. Those entering hospital, are they double vaccinated? Do we know the percentage of that age range that are double vaccinated entering hospital?
So I don't have local data on that, but I did look at national data for the sort of 5 months from February through to July. So obviously that was the earlier in the vaccine rollout. And if you look at national data, the rate of the proportion of individuals who contract COVID who've been vaccinated with 1 or 2 doses was 1 in 200, but for unvaccinated people it was 1 in 20. We know that the evidence shows that double vaccination reduces the risk of severe disease and hospitalisation by about 95 to 96%. So we are likely to be seeing some people who are double vaccinated in hospital, but a larger number or a larger proportion of those unvaccinated are likely to be hospitalised. Obviously, a large proportion of the population now is double vaccinated, so the absolute numbers are likely to be higher in that group, but proportionately lower, if that makes sense.
I noticed we're still at 65% for vaccination in the second jab. I know we sort of hit a brick wall in trying to get people to have this. I guess we're lost for ideas on, apart from driving around the coach and dragging into the back of it and jabbing them. I'm a bit lost for ideas what we can do to get people to have this vaccine. Sorry, Joe, I can see you're really struggling to hear.
Sorry.
Is there any other suggestions we can do to try and get more people to have their vaccine?
I mean, we've really done, you know, we've really tried to be quite creative and inclusive about this. We've done a lot of research on vaccine hesitancy in Thurrock, so we engaged a social marketing research company to do some work on that. We got some really key messages out of that about what people's concerns were. So a lot of the concerns were about the rapidity of the vaccine development and sort of associated safety concerns. There was also, I suppose, a set of concerns that were related to issues regarding fertility, pregnancy, breastfeeding. So different groups of people had different types of concerns. We've done a lot to try and address those. We've participated in a range of, sort of community dialogues. We've produced short videos that we've used on Instagram and other social media to try and get people to click through to slightly longer videos that talk about that there isn't a risk to fertility, for example. So we've done a lot of that. We've analysed the uptake by geographical area, age, ethnicity, gender. We've got obviously the mobile vaccination units. We've got several now in the borough. They have gone out to those groups that are seldom heard, that may not access services through regular routes, such as our traveller and showmen population, and that's been really successful actually. We've also sent them out to the geographical areas where there's lower uptake. There's a work programme across Mid and South Essex focusing on high need, high risk groups such as pregnant women and trying to reach them through services they're linked into. So there's been a huge amount of work to try and understand people's hesitancy, support them with understanding and just make the vaccine as accessible as possible. But yeah, I think particularly over 30s, the numbers now have really pretty much paused on vaccine uptake.
I noticed we've got the vaccine bus at Lakeside car park again. Once again, it's sort of hidden away in the car park and not in the main area of the car park. I still would like to see the ambulance-sized vaccine bus that visited Corridor Town Centre to be inside the centre itself. I noticed there's some lower level parts in Lakeside where you can actually park like it's an open shop front where you can actually park the ambulance vehicle in there and offer vaccine. I just feel if we're offering it right in the heart of the shopping centre, we may get a better hit. Also, do we have any information on the second jab for 12 to 16 up? 12 to 16 up. They're just having one. We're not going to be offering a second jab.
JCBI.
Right. So that's the sign at the moment.
Yeah, it's not something we could go with.
While you're talking about the younger groups, I know there was we've done a lot of work, everybody done a lot of work around the hesitancy for the sort of 20 plus, where they're concerned about fertility. And we had Dr. Sharma talking to people and having sort of events where it was, the best that could be explained was explained. That hysteria is nothing compared to the 14-year-old girls. And I've got a granddaughter who lives with me. And I can assure you they are whipping themselves up into a frenzy. So when we get the forms home as a parent to give permission, And I spent a long time talking to my granddaughter about it and trying to alleviate her concerns, even that, you know, we could grow a towel in 10 years' time. And I said, well, at least you'll be here to grow a towel, and hopefully you protected me, I'll be here to see you grow the towel. So there was all of this discussion. So we done all that. She went off quite happy. She came home that afternoon. I said, how did it go? She said, didn't have it done. And I said, why not? What happened? And she said, well, when I got there, they said, do you want it? And I said, no. And she said, okay. So it was all a complete and utter waste of time. And I'm not saying you should chase 13 and 14-year-olds around the school and jab them regardless, but maybe there's some work to be done in their assemblies from somebody with a medical background to explain that it is, you know, the same sort of work that we've done with the rest of the communities. Because I think they are the ones that are passing it around left, right and centre. And if we can hit as many of them as we can by making them understand, somebody telling them, you know, alleviating their fears, maybe we can get a better take-up than we're getting of that age group.
My 12-year-old grandchild was quite eager to get the jab. So he had his jab about 4 weeks ago. Last week, tested positive for COVID. So my 18-year-old grandchild, who's like, no, not having it, is like, but he's had the jab and he's got it. And my son and his wife have now contacted COVID, although they've both been double jabbed. And so we've got an 18-year-old who's saying, oh, what was the point in that? And so to say to them, yes, but people aren't now dying and going into hospital, it's like, well, that is the problem with that generation. They don't want to be dictated to. You should be having the jab, and all they say is, if you say to them, we are protecting nan, granddad, mum and dad, it's blackmail.
Joe, do you want to come back in?
Yeah, I just wanted to say, so EPUT and the school age immunisation service are rolling out the school-based vaccinations. They've been to talk to all the head teachers at the regular head teachers meeting and have offered to do exactly like Kim is saying, to go into schools and sort of do information sharing as well as, you know, just administering the jabs. So that is an offer that's in place from EPUT.
As now, then Councillor Holloway, then Councillor Pickler, then Councillor Fitch. Councillor Smith.
Okay, I'll start by saying I've had both of my jabs, and at the time I thought it was the right thing to do, and by and large I still do. However, has anybody around this table ever heard of something called Gentleman syndrome? Nor had I until my son got it about 3 weeks after having his first jab. Then a week after him, a colleague of his also nearly collapsed and died and was diagnosed with the same syndrome. I now know that a further 2 people, within 3 weeks of having the jab, have been diagnosed with Gentleman syndrome. Now, apparently it's very rare. I myself know 4 people already have got it after having the jab, but didn't have it before. Look it up, it's quite rare. So there are concerns, and you know, people are getting reactions to this. I'm not saying it's super common, but people are getting reactions. Now, my reaction to it is extremely minor, but it's irritating. I've now got an itchy arm, and it's itchy all the time. It never used to be, but since jabs, it is constantly itchy. To the extent that I've got a little scab that's there the entire time, I keep scratching the blooming thing. So there is going to be a cohort of people that have not had the jabs yet, but are hearing these stories, and they're not stories, they're actual things that have happened to people, and they're going, do you know what, I'd rather not. Because certainly the younger people, they're going to take the risk of catching the thing, because they're going to get a little bit ill. My partner has had COVID. She got a little bit ill. She was far worse a few years back when she had the flu. That was really worrying, but this COVID, admittedly she's had the jab, was minor irritation. I know a few people that had COVID after having the jab, and they've been a bit ill, but they've not been terribly ill. So I guess that's the point of the vaccine. So that's fine. But you're never going to get everybody going to take it up, because, as I say, especially now when there are these stories coming through and people are suffering reactions from it. So, you know, there's always going to be a hardcore that no matter what you do, will not take it for those reasons.
Yeah. Hi, Joe. If you can hear me, can you just tell me if we have any data on the booster jab? So, like, the booster jab for people that are eligible, and do we know how many people have taken that up that can? Very generous. Okay.
I don't have it to hand, but we can probably find it. Yeah, I don't have it in front of me at the moment.
Thank you. It would be good
get
to
it
know.
for our NHS colleagues.
It would be good to know because obviously, like, we're hearing nationally that lots of people aren't taking up the booster, and we know that obviously after the second jab the effectiveness wanes. So I wondered if that was similar in Thurrock, and again, if we have to do that bigger push about reminding people, because yeah.
I think part of that as well is that people who've had the 2 jabs, my son and daughter-in-law have now got COVID. They're obviously under 50, so they're not yet eligible for that 3rd dose, which they both will get. But my daughter-in-law has had a cough and feels a bit tired. My son has got it since then. He said, actually, I feel great. But he's got it.
Well, I think the other thing to remember is that vaccines actually don't stop you from catching the disease.
Yeah,
they just stop you from dying from it. So
stopping you. And
hopefully,
therefore, people are saying, well, why am I having a booster?
maybe again we need to think about the comms so it's clear that people understand that
Yes.
it doesn't stop you from
Yeah.
catching whatever it is, but it does stop you from being very, very sick from it.
That's all.
No, just that obviously there's, and I assume it's nationally, but to take up by 14-year-olds and that is that low nationally or just particularly to Thurrock?
Yeah, we are. I don't think we're too different from national. And I think it's partly, I mean, as has been noted, that there's partly issues of hesitancy, but I think it's also that the rollout is being done through schools. And certainly in Thurrock, what the service is doing, they're using appointments with schools that had already been made for other vaccinations. So like the HPV vaccination, they've repurposed visits they already had planned. So they're having to go through a timetable. It's not the most rapid rollout because there's limited capacity because the service is not designed for a rapid rollout. It's designed for an annual programme of going around the schools. So there's, yeah, so I don't think we're particularly an outlier in terms of uptake in this age group at the moment. But we are generally lower than national rates across all other age groups for some reason.
If it was a national problem, I'm just wondering whether or not, and it seems it isn't now, so, but whether they get on an idol that 14-year-olds look up to. If it's a national problem, that's willing, has had it, and is willing to say something, just to go out and promote it, to say, well, I've had it.
Do you know, I will say, thank you, Joe, for your email earlier, by the way, breakdown and fun. It was quite interesting to find out that also, this is more local. Some areas in the Thurrock go for it, SS17, so we're really good at getting vaccination. And our areas like Grays and Tilbury are really low. So there's definitely that change in people's belief systems. It's hard. It's really hard. Councillor Fish.
Yeah, on the booster, I haven't had my booster, but because I got a text to say that I need to have it done. My second jab was in March. But so I tried to do it online and it wouldn't accept my postcode. It said it wasn't a valid postcode. So it made it very easy. Then I went on to 119 and I got an appointment the next day. The place I went to was in Tilbury. I mean, I didn't actually tell them that I'm a wheelchair user, but it was totally inaccessible for a wheelchair user. So, you know, I mean, there's issues like that, and that seems to be all the way through, actually, in terms of accessibility. It seems to be the last consideration, even if it's got one-way systems in shops. But my other point I was going to make earlier, anyway, before we start talking about boosters, is there are figures there for mortality rates, as far as I can see. there's hundreds of people dying nationally every day. I mean, are any of those people from Thurrock? And considering people are supposed to have had 2 jabs, what is the profile of those people? Are they extremely clinically vulnerable, or what?
So, sorry if I think I've heard that correctly. It was about mortality rates. Yeah. So I don't have numbers to hand of recent deaths within Thurrock. I think it's low numbers. We're getting low numbers of hospitalisations. I think it was about around between 7 and 10, I think, in the past 7-day data that I saw. So we are getting some people who are getting very, very seriously ill with COVID. I don't know if Mark's got any more data on that. I mean, I think the profile of deaths has changed over the pandemic. Obviously, we saw a lot more deaths in care homes, for example, earlier in the pandemic, and that profile has changed somewhat now. But I don't have local data to hand, I'm afraid.
There were 40 people in Basel Hospital who were COVID positive. So that's the last data that was reported to us. I don't know how many of those were from Thurrock. It's reason to assume that probably about a third. The other thing you've got to be really careful about with hospital data is causality. So when we looked at this previously, what we found is the majority of people in hospital, something else would have been in hospital anyway, and anticipated. Either they came in with it asymptomatically, and or they caught it whilst they were in hospital. So it's dangerous to just take raw hospital bed data and assume that is being driven by COVID in the community. Yeah.
Mark, is there any outbreaks in Basel Hospital at the moment?
So there are, as Ian said, there's 45 COVID patients in Basel Hospital, and about a third of the ITU beds are occupied with COVID patients. So they are managing some very ill people with COVID in the kind of highest level of intensive beds.
But you don't see no real spread within those groups itself?
Not
transmission?
There are no reported outbreaks on the data that I'm looking at. The hospitals are just extremely busy generally. There's kind of, they're operating at a kind of level 4 alert and very, very high attendances in A&E, over 400 patients yesterday generally. So level of activity in hospital is very high. There are over 100 COVID patients across the 3 hospitals, so they are managing COVID, and there are some very sick people in ITU with COVID as well.
That's like coming to flu season now. And really extreme colds that people seem to be getting. We've been locked up for a year, haven't we? Yeah. We've been exposed to these viruses that we're not used to no more. So yeah, it's really, and obviously the backlog of not being able to get doctor's appointments is going with more complex issues, so it makes it harder to join.
Yeah, the pressure is in absolutely every part of the system. Primary care is under pressure, on health services, acutes, ambulance, 111, we're seeing sort of very, very high levels of activity in all parts of the system. So yeah, there's it feels under a lot of pressure quite early point in the winter period. So obviously concerned about how this will progress over the coming months.
Yeah, I understand the stage you're at the moment is normally where you'd be coming up to the end of December.
Yeah, kind of long peak period, sort of end of December, January, February, and yeah, we're hitting those numbers. So as I say, 400 dependencies at A&E in Basildon yesterday.
Any other questions? Thank you, Joe. Thank you for that update. Okay, item 10, adult social care, consultation feedback, the meal delivery and daycare services. Can I ask Dawn Shepherd to present this item, please?
Chair, I was going to kick off and then I'll hand over to Dawn. So,
okay, brilliant.
Just
Ian, start, please.
That's what I promised Dawn anyway. So,
I'm doing it, Ian, if you want me to.
I was just going to say, I also remember that we brought a paper in the summer on the wider transformation proposals for provider services. There's 3 elements. The first was the following successful pilot for wellbeing things to roll that out as the service model. Home care, which was far more holistic and long-term care relationships. Second was rationalising of daycare services onto 3 to 1 sites and to have a more comprehensive offer. Including mainstream sitting service, and there was closure of the delivery service, replacement or bespoke options for residents. Host rightly, my view, requested that we consent services be done, so we've done individual consultation so to every service users of both daycare and the delivery services, and this is the report that we've asked for that details the findings. The report is positive, and the results are positive, but I'll hand over to Dawn to take you through the detail of the outcome. So, the consultation. Dawn.
Sorry, and I couldn't hear you very clearly. Do you want me to take you through the outcome, the consultation outcome?
Take us through the data itself, please.
Yeah, thank you. Okay, so if we look first at the daycare services, you'll notice that prior to the pandemic, there were 54 people who attended the 2 daycare sites at Kynoch Court and Bell House. Unfortunately, 7 of those people were unable to take part in the consultation because they'd either moved into residential nursing care or unfortunately they'd passed away. 47 people did take part, and they were either telephoned or visited to discuss their views. 30 previously attended the Kynoch Court site, and the other 17 attended Bell House. When they were asked if they were willing to attend the Cromwell Road site as an alternative, 33 said they would, 13 said they wouldn't like to, and 1 was said possibly. When asked why they wouldn't like to attend, 7 people indicated that they no longer required the service or they were unable to return to daycare generally due to their deteriorating health. There were an additional 5 people who said they wouldn't attend due to the distance. However, as you can see from the report in section 3.1.4, all 5 of them had alternative support in place. So overall, there were no concerns identified that anyone would be left without support. While we did the survey, we took the opportunity to find out how people's health had fared during the pandemic, and unsurprisingly, there were very high numbers of deterioration in mobility, mental health and physical health. And you can see those percentages in section 3.1.6 of the report. And we also asked people how they'd found the sitting service, which we'd increased to provide extra support at home, both during the pandemic and which has continued whilst the daycare centres remain closed. And there was a really positive response, with almost 90% of users finding the service to be either extremely or very good. So within the new transformation programme, the sitting service will continue to grow and it will become part of the mainstream support offer. Plans will include the introduction of an activity coordinator, specifically to help people link into the new virtual daycare offer by assisting with ICT. And what this means in practice is that someone will visit people at home and help them to access the required programs and apps on their phones, their tablets and the PCs. So since June, we've done a lot of work down at the Cromwell Road site to enable greater space in preparation for reopening. And we plan to offer an improved menu of activities that people can pick and choose from, and you'll see from the report in chart 5, people indicated the sorts of things that they'd like to do, and so we will be incorporating those. The plans are to reopen Cromwell Road in early February, subject of course to health, safety and infection control sign off, and we will plan to hold an open day event inviting the local community and neighbours along to relaunch the centre, and of course we'd like to extend that invitation to members as well. And then if we could just move on to the meal delivery service, again we undertook an initial survey during the summer with all 89 people who received a delivered meal. So this was only an initial discussion, and obviously more detailed and individual assessments are due to start next week actually. So chart 6 in the report outlines the areas that service users live in, and you can see that over 30% of them live in the Grays area. We asked the assessor, who was a qualified social worker, to recommend one of 4 options that will best meet the needs of the service user. And you can see the results at 3.2.3 in the report. So 24 people identified that they could actually make their own arrangements. And since we carried out the survey, 6 of those have already cancelled the service. 37 people already had a support package in place, and we're going to be able to reassess that support to ensure that a hot meal is provided. And when you look at the chart, you'll note that there's one person on the chart who we were unable to contact at the time. That person has now been assessed and is one of those 37 people. 4 people live at Pigs Court in Grays. So this is an extra care scheme with carers on site 24/7. It has a daily cafe Monday to Friday that provides a hot, freshly cooked meal on site, and it also offers the opportunity for residents to meet together to eat if they wish to. But if they don't, then the meal can be delivered to their flat, and arrangements can be made for extra meals supplied at the weekend. So this provides an improved offer, not just to those 4 people, but also opportunities for others to attend the cafe rather than eating a meal at home. So that just leaves 24 service users who wouldn't have anything in place if the service was removed. Now, these service users will now have a needs assessment to determine the best alternative for their individual needs. And we do understand that people don't like change, and it can be a very worrying time for them. So we have a dedicated support planner who is going to be meeting with every service user now, not just to look at the alternatives, but also to assist them with putting them in place. And alongside the consultation, we've been looking at lots of alternative solutions within the community to identify different service offers. And we invited some community groups and individuals who provide meal services to a sharing event in September, and we now have a directory of options that the support planner will be able to use. So again, we just want to reassure members that a meal delivery service will still be provided to all current users until suitable alternative arrangements are made. The proposals outlined in the report will offer individual plans for those currently receiving the meal service, and these plans are designed in a collaborative approach with service users, their families and carers, as requested at the June meeting. And finally, I can just confirm that a report will go to Cabinet in December, which will again outline all the proposals and consultation, allowing the final informed decision to be made. Thank you.
Thank you, Sarah. Where do we start? First of all, it's quite a positive outcome, the consultation. Very happy to hear that these people have taken up the offer of relocating to the new location, and excited by the new prospects of some of the things that can be offered now. I was cautious about the consultation. I was worried what we was going to find. To hear the positive feedback from them themselves has been really good. When it comes to the meals and when it comes to the food delivery service, I do have concerns that these 25 people, what did you say, 24 people, are still, it's not no guarantee at the moment. I see we say they're not going to go without food. It's that I want to see further down the line more ideas put into place what can help them. I don't want us to go down any further route without them having more reassurance that something is in place and the guarantee that not one person will go without a meal. It's their lifeline at the moment. That's what they have. So that is what I would like the reassurance from. It's good to hear that the other people have come up with other ways of having support and having meals delivered. Or I mean, I do understand we're in a modern world now. If people are a little bit tech savvy, they've got ways of accessing food with Deliveroo and all this sort of stuff. But there is a health and age consideration involved in that. Before I joke, I'm going to pass it and go to the people.
Yeah, I'm just looking at some figures here. I'm possibly reading it wrong. So perhaps you can help. There's quite a high number of percentage of people that were prepared to go to Cromwell Road to get, to carry on the service there. Now, I understand Cromwell Road is the option to get a hot food there or a meal there. So I find it hard to see how then, if you go back to the figures that says that people aren't going to be able to get a hot meal, they don't tend to tie up. Because it looks like there's more. There's only 13 people that don't want to go to Cromwell Road, and yet there's 27 people that don't want. Saying they can't get a hot meal. I don't know. Perhaps
they're not the same cohort of residents. So the consultation with two different issues: those that access daycare and those that access the meal service. And the ones that access the meal service wouldn't necessarily access the daycare. The ones that access daycare wouldn't necessarily access the
Councillor Holloway.
Thank you, Chair. Yeah, and thank you for the work that's gone into the consultation and speaking to residents. That's I'm really glad that happened. I agree that I think I would just like some firmer details on when the 24 people will be assessed, because obviously we say that they will be, and when will that happen, and when will they have those plans in place, because obviously the uncertainty overhanging those 24, we want to kind of put that to bed as soon as possible. And I don't know if we need a report back, but if there's an email to all members of the committee, I personally would like to know that those 24 have those plans in place. The other concern that I have is just about, although with regards to the Meals on Wheels service, and although we don't call it Meals on Wheels, whatever we call it, that term was always synonymous of supporting our older residents with meals. So although it's not technically that, we know what that means when we say that. And I wonder what we will do for residents now who will say the Meals on Wheels service is no longer, and they then may not realise that we will still be able to support them in providing hot meals, and may just never come to the council for help where they need it. So what will we be doing just to make sure that older people know that we are still there to support them with things like hot meals, and to direct them, as that they will, it will soon spread that the Meals on Wheels service, as they believe it is gone.
Thank you. Yes. So first of all, with regards to the 24 people being assessed, absolutely, those assessments are starting on Monday. We anticipate that will take probably six to 8 weeks, I think, to get through absolutely everybody. So yeah, possibly by the end of December, I think we will be able to come back to you with some sort of reassurance around that. In terms of people knowing about the service, as it stands at the moment, people come through an assessment process, and they can still come through our single point of access, Thurrock first, if there is a need. Generally, I think people, there are lots of options out there now. I think people are aware of more options being available, but in terms of actually, you know, advertising or making people aware. It would be down to those individual groups that are out in the community to be able to do that, and we would encourage them to do that. So, for example, we have a new provider who's just setting up in the Corringham and Hornsey and Alsett area. So she will be advertising her meal service, not just maybe for people who really need it, but people who want it as well. So it becomes, you know, much more accessible to everybody.
Okay, thank you.
To come back to Kim before I bring over to Councillor.
Okay. Just a couple of things really. Obviously, all of these 89 people at some stage were assessed as needing this service. So we've now got 24 that don't need it. So it's questionable as why they were assessed as needing it in the first place, and now they've suddenly decided I don't need it. And is their decision not to need it is around a cost implication to them? So it's cheaper to say it's all right, don't worry, I'll manage myself, than carry on with it. Because if they were able to buy and cook their own meals, then it doesn't make any sense that they were receiving the service or assessed for the service. So that's
just coming on that one. So I think you're confusing two slightly different things. One, an assessment of need, and the second is service.
right.
So they were assessed, and we will continue to assess them under the Duty and Care Act. Some is assessed as needing support in terms of cooking or eating, and with a legal duty to make sure that that support is in place. How that support is provided will be through a whole range of different options. So they were never assessed as needing a meals on wheels service. They were assessed as needing support, I would imagine, in terms of cooking or meals in general. But it's then, and the Care Act, as you probably know, is about actually providing both individual solutions to residents rather. It's quite old-fashioned. I don't think some people practice it. So this is, we've got a one-size-fits-all. This is your one option if you have that need. So yeah, it's not quite the same thing.
And a bit then about the service to users that already have a package of care. Will that package of care be increased to provide that meal? Because obviously they wouldn't have that in place, would they? Or would they? This is what I don't understand. So they've already got a package, so many calls, and it's not including a meal at the moment, or does it include them?
So that's what the assessment will do. That's what I mean by bespoke. And actually, also that care point is not, and those needs are not fixed. As we know, people deteriorate, some improve at times as well. So which is why the assessment process is dynamic and repeated. So that if they are assessed as requiring support with a meal or cooking, then we would look to work with them to work out how best they would like that need met, and that could be through a whole range of different options. It could be through having a meal delivered, it could be through access to services, a fixed call would be one of them, it could be a meal at daycare services, it could be that they have practice, it could be a microwave, and that's very much their choice.
And just to ask, fixed call now, I mean, obviously we know that there is a cafeteria in there and that the residents, but at the moment, that's not accessible for people outside because of COVID restrictions. So when this hits in the new year, if that cafe isn't open, is there a backup plan for that? Because we're going to start directing people there.
There needs to be a backup plan for every single person, is what I'm saying. Yeah. We have a legal responsibility to ensure their support needs are met. So there will be an individual assessment, an individual plan, and we will not. What we will not do, and it says it in the report, and I say it again, we will not close the service if it's someone without their support needs being met. Because yeah, it'd be morally wrong to do it.
I didn't ask for a consultation. I asked for the service to be co-produced with service users, if possible. So I wonder what happened to.
So that's exactly what is happening. So I'm saying to you, so we would work with each individual service user to agree with them how they would like that support need met. What we're not going to do is work. As I say, it's very old-fashioned things in terms of let's just create another service and then everyone has to get that service. So the co-production maps of the individual will not be designed in the service there, that will happen.
That is really good on the one hand, because it is obviously one size doesn't fit all, but how do we ensure that there's like a continuity of like standard that one person's care is as good as the next person's care? Is that evaluated where the person feels happy? How would that be done?
That has to be defined by the individual, isn't it, rather than the service, because if it's defined by the service, it doesn't take account of the different needs, wants, desires of the individual. So it doesn't, standardisation doesn't mean being the same, but to say how I might want my mobility needs met may be very different to how my mobility needs met, depending on what they wanted to do in terms of mobility in their life. So yeah, it's got to be defined by the person who's experiencing it.
Do you know, just dawned on me, and it's something stupid. Because this can be a bespoke service, there could be.
It's going to be bespoke services.
There is a chance that someone will have the opportunity to book their meal. It could be provided by any service they're using delivery. They may have their care worker organised to book them a weekly or daily meal, whatever. We can have some sort of quality check that they get decent quality food. You know, something like ordering McDonald's every day.
I respectfully say I don't think that's only the council's business. Just as I don't think you're right. Please come around your house and check what you're eating.
Just when we do the meal delivery service, it is quality food, nutrition. We don't want to lose that balanced nutrition food because that's going to have health implications.
Or maybe, sorry to intervene and add to that, that there's a varied choice, because sometimes you might say, oh, I want this one day, and then you'll be like, yeah, I'm going to eat that juicy takeaway one day.
Any good social work practice would encourage people with a positive way to make health choices and to enhance their well-being as much as possible. But at the end of the day, it's a person-centred service, and you have to respect people's wishes in terms of the food choices that they wish to make. It wouldn't be bad to
It has been done.
No, we provided a one-size-fits-all service that people may or may not have.
Based on nutrition.
Yeah. But, if people decide that they want to leave their food feast by ordering a Chinese takeaway every night, it's not. I may not personally approve of it, and I may not think it's best in their best interest, but ultimately we will have agency there for this. I wouldn't want to live in a world where the state says you can't do it.
No, just quickly, I can see the sort of ups and downs of it, but one of the ups for it is that they will be choosing what they want, when they want it, and that could actually lift their well-being, because they're no longer thinking, they could actually feel better for having a Chinese, rather than having shepherd's pie that they have because it comes, but they don't really fancy it that way. So, you know.
Very good.
I've just been got back, I do apologise. Okay, so our recommendations were, one, I think, will be to try and have an update of the progress that you have once the reviews done.
Yeah.
Give a figure briefing note in December.
That's it.
So we'll do that briefly.
Yeah.
Yes, please, yeah. Apart from that, I think it's a very positive outcome. And thank you for that. Moving on to the work programme. Okay, so we did receive a briefing note on the housing maternity unit. I don't know if members have a chance to read that. I would like, obviously, we couldn't bring any questions in today, there's no one here to answer them. Do any of you have any major concerns from reading the report? No, we don't want to bring them back in after that.
I mean, I would take it on advisement from when appropriate to come back and see. Obviously, there's lots of things that they wanted to do with regards to recruitment and bedding down a lot of the things. I'm not sure. I mean, I would absolutely happy to bring it back to the committee, but take it on advisement where appropriate, where we can benchmark, like when they've got the people in or the midwives that they wanted to recruit, and you know where they've done that, you know, evaluation of have things turned around. But again, as I said, take it on advisement of when best to bring that back to committee. It'll probably be next year now, I would say.
Yeah, well, after reading their update, I was thinking sort of like more like April time, because once they've got the staff that are in trade and trained staff, perhaps we can see more through July.
June or July.
For the election, so it'd be March or
We'll go July. So we give them a lot more time. And obviously, I do know the improvements that are being made there as well. Apart from that, the other thing, yeah, what got years? As you know, we were asked by the Scrutiny review to pick a topic. After consultation with other members regarding outside members of this committee, the mental health board group is being set up. Now, as part of our scrutiny review, we was asked to pick a topic that we can actually focus on and claim for ourselves. Now, as we looked at was the mental health waiting times, because some of that work will be carried out by the mental health board, we won't be able to say that that's for the hour. So there's been a slight change of work. In discussion with some other people, we've been looking at, and as noted today, in the review of the health and wellbeing, there is nothing about alcohol. And alcohol is also one of the major influences on public health, on Basel Hospital. As I say, as I've got a message from the leader that when he's in there recently with a chest problem, everyone else in there was drunk in A&E. No, that obviously has reflections on addictions, mental health, on crime, on antisocial behaviour, obviously. So what we'd like to be focusing on, and I know Ian, you are concerned about the workload that this could bring for Joe and everybody. I will be contacting us as a group to bounce some ideas off of you of collating data, information, and what we'd like. It may be sort of down to things like license premises, we open Thurrock, and tracking some stats on addiction levels. I know we have places like Open Door and all that money that have visions that can provide data and information. So I will contact members outside of this committee to put that ideas over. But again, it's because the change of focus, because the mental health board that is being set up, members board will be claiming some of that on the mental health waiting times.
Can I just be clear again though, what I said to you outside this meeting, we can't at this stage add any more informatics to the health work programme, which is stretched to it as it is. So happy if you want to look at this in the detail you were suggesting the other day, happy to do it. We need to be in the next month.
Yeah, I'm going to have this with the leader, and basically he's giving the guys to request this to be put in place.
Sure, but
and I do not say we're not, even if we get to a stage where a report can come through in April or something like that, before whenever the end of this, it could be seen as an ongoing project as a roll on. That is because the role of HOS is to identify areas not being covered within the year. And outcome wasn't. It was, but not to detailed levels. The amount of times I've been here now, what, 2 years, we've had very, very limited stuff come to us about alcohol addiction. Lots about smoking and all that. I don't think I can recall anything coming here about.
Just bear in mind what Ian said about the pressures are under at the moment. I don't know how even in the timescale you found, there's just a framework of what they would look into with further detail.
Yeah.
What are we going through? So at least we've got a baseline, so there's no in-depth work done on it. It's just saying,
Yeah.
these are the 5 areas that we think we need to look at. Do you want to add something? And that can go on after the election or whatever.
So I think what we could do is provide the nationally available statistics. We could provide a scope for next year. But
I mean, so if I said to Mark, you know, if I wanted to get data from alcohol attendances to Council Hospital, by AIM, I know you don't keep those records, and that could be seen as a heavy workload for those figures. And if you used to say to me, well, look, everyone in the back room is working on COVID stuff, I can understand that. But those figures are available. It could be, and I've seen talking to a few people how it's crazy. So I wouldn't say it's really an out of the world ask to provide some sort of data on that.
Just a couple of things on that, and you know, happy to kind of think about more outside the committee as members. I do question whether or not, you know, would you guys be referencing, I assume you're group leader, the leader of the council, which is, he's not relevant to this committee. We decide as committee members. I absolutely don't feel comfortable whether or not he wants it on the agenda or not. That's really not up to him. That's up to us.
It hasn't said he wants the agenda. I just asked the feasibility of the workload of officers.
Oh, okay, no, that's absolutely fine, but just want to be really mindful of that. And I would think, again, having to go outside is, again, what do we as committee members want to do ultimately, which is, if it is to kind of, is it public awareness around the issues around the campaign? So to kind of think about those kind of things, and then see what Ian's workload is in, and try and get some quicker wins on kind of if that fits in with the workload, so that we can get things done sooner rather than later.
Oh,
so
yeah, I mean,
happy for that discussion to happen, but just to get on what we really want to achieve as committee members on this particular topic, and then advise officers.
Do you know what? It's things like people not realising the strength of different types of beer compared to other things. Yeah, it's things like that where people go out and you know, the ease of access to alcohol at this age. You know, you know, we have a massive implication. You know, if someone gets drunk, we've got problems up local town centres where people are trying to buy alcohol or whatever.
Yeah, well, I think we also might want to think about, do we want to write to our MPs? I mean, the Chancellor just reduced, you know, the cost of alcohol, like that's
absolutely
not ideal, is it? So things like that, we could look at kind of those wins.
Oh, we're still on the same boat now.
Well, rather than, I don't know, like traditional reports, can we think outside the box that might increase, like speed up what we want, is what I'm saying.
Yeah, I mean, you know, we used to provide, as a council, how to measure your alcohol intake and where it shows your dependence. And we used to be able to come up and we used to give them out. And I believe there's still tons of them in boxes somewhere that we can access. So these are sort of things we can look at. And it's that awareness, social awareness. Also, to have people to think a little more about the impact.
It might be the comms team rather than the public affairs team we need
to
speak
to.
Because
they're saying it is a public health issue.
It is a public health issue, but I say again, I cannot add anything else to the public health matters we're planning.
Happy to go and talk about it as members if that's helpful, Chair.
Yeah. As I say, I was referencing it just because I was asking about office worker. It was just regarding Matthew Butler's email today.
You know how I feel about outside involvement in that committee, Chair.
Yes. Okay, and on that note,
I just add something to
sorry.
About obesity strategies. It's particularly interested in mine. It was on the work programme last time, which I was pleased to see. I can't see it this time.
I think it's coming as a briefing note.
Yeah.
Joe's working on that now, and that should be soon. Joe?
Yes, we're just finalising it now. So we've done a briefing note for the committee that we should get out to the committee in the next week or so.
And that will be open for discussion.
Yes, when we do the matters of urgent business, you can now talk about briefing notes.
Okay.
Joe, on the obesity thing, can you try and get some data on the amount of takeaways we have in Thurrock?
Very upsetting. I'm not taking
Sorry.
very upsetting. Everything in moderation, Chancellor.
Yes, it is in moderation, but when you have 27 in one area, it's...
I think.
Well, 27 Stanford and Cohen.
Sorry?
stamp it up.
There's nothing you can do about it.
No, but we just had the betting shop, which is.
Oh, do you mind to take away venues?
Yes.
Or if it matters, we have a meal or something.
You would be judged with me by then.
Well, believe me, people in the care homes that need rules or delivery services will great opportunities.
How on earth can we assess the number of takeaway meals?
Yeah, brilliant. Okay, thank you.
Oh, sorry, I was going to say.
So, we go on to what program? What was it on your one?
I just wanted, just for accuracy, because we have the overview of responsibilities for the portfolio holder for health in the
Yes.
September
Yes.
meeting.
Yes.
It wasn't there. To remove it, but if anyone has a look, because it didn't.
Well, we try and get that for the next one.
Yes, so, and then, communities after, isn't it?
Well, we'll see what's on the work programme, and we might be able to get them to both of them in, or.
But just for accuracy, I don't, sure, you might forget and think he came to me when he hosted.
I'm on it.
Well, no, I don't, but that's what bringing it up to the point of principle now, isn't it?
Okay, you're closing it, shall we go?
Yes, lovely. That concludes the business of the meeting this evening. I now declare the meeting closed at 9:20. Thank you.
Thanks, Joe. Night.